Good afternoon, everyone. Thank you for coming, despite the nor'easter. I want to welcome all of you. My name is Dr. Magda Alianson. I'm the coordinator for the Employee Assistance Program here at SUNY Downstate. I work in conjunction with the Office of Diversity and Inclusion, our speaker, which I'll talk about a little bit later, and Shondell Goldsmith, who's the director, as well as the administrator, Ms. Tahisha Williams. Today, our lecture is a part of the EAP series of lectures, and it's in honor of Black History Month. There's a series of events that took place for Black History. One of those was last week. Of course, we had the president with our guest speaker. And today, a second series of events is our speaker today, Mr. Kevin Antoine, who's the AVP for the Office of Diversity and Inclusion, my boss, Chief Diversity Officer. And just to give you a little bit of background about Mr. Antoine, because we see him all the time, but it's always good to get a little idea of the individual who you're seeing. As a Chief Diversity Officer, he has oversight of the campus affirmative action program and ensuring compliance with state and federal laws related to equal opportunity, as well as developing and implementing initiatives related to campus climate and inclusion. Kevin oversees the administrative process for investigating complaints of harassment, discrimination, and retaliation. Before joining Downstate Medical Center, Kevin held positions in federal and state government, higher education, and U.S. Air Force. He has served as the legal analyst for the Federal Judiciary, Chief Diversity Officer and lobbyist for the City University of New York College of Staten Island, and a Harvard Administrative Fellow. Kevin was honorably discharged from the U.S. Air Force at the rank of captain, AKA, that's why we call him Mr. Captain. Kevin is a Fulbright Scholar and a graduate of Harvard University's Administrative Fellowship Program. He earned a law degree from the College of William and Mary School of Law, an executive certificate in change leader and organization change from Cornell University, and an undergraduate degree in political science from the University of Southern Mississippi. He is also a graduate of the State University of New York's Executive Leadership Academy. He has a candidate for the United States Congress and the New Jersey State Senate. So without further ado, Mr. Kevin Antoine.
Buenas tardes. Good afternoon. Ohayou gozaimasu. Konnichiwa. As you know, I like to give my greetings in multiple languages because here in the borough of Brooklyn, more than 150 different dialects of languages are spoken. So I feel remiss if I don't try to attempt to say it in a few words. Good afternoon. So bonjour and guten Tag. Shalom and assalamu alaikum. So today I'm honored to accept Dr. Alianson's request to be the speaker for today. I just want to say that it's been less than a year, I think, that she has been into the job. And in the 10 years that I've been here, she's really taken the EAP office to the next level. She's been doing a lot of hard, good work, minimum staff, but I just want to give her a hand and a good shout out. And of course, Mr. Tahisha Williams is the office administrative assistant, so she's like handles all our stuff, right? You know she's overtasked. Then of course, I can't forget my right-hand man, Ms. Shondell Goldsmith. I know, I'm just teasing with her. My right-hand woman, Shondell Goldsmith. As you know, lawyers, if they're going to be good, they need their own lawyers. So I want to welcome everybody for coming to the program today. So the title of the program, The History of Cultural Competency in Healthcare, and going to provide some cultural competency training from a modern aspect. So I just want to give you a brief background on what we're going to do. When I was a third-year law student at the College of William and Mary, William & Mary is the oldest law school in the United States. They have this running thing with Harvard. Harvard is the oldest college, undergrad admission. William & Mary has the oldest law school. So Harvard has the second oldest law school. And William & Mary has the second oldest undergraduate population. So we go back and forth with that kind of stuff. Just some fodder. So as a third-year student, at William and Mary, unlike other law schools, we have to do a graduating paper, a thesis. So I did mine on Reconstruction. And it wasn't what my advisor wanted me to write on. At that time, President Reagan was the president, and he wanted me to write on judicial activism and the judges that President Reagan was appointing. I had no interest in that, none at all. I wanted to learn more about Reconstruction, so I did my paper on Reconstruction. And so I have to tell you, that knowledge has stayed with me all those years later. It's been 20-some years, and it is relevant because what I'll tell you just briefly, and we'll get into it, is that the modern Civil Rights Act that the Kennedys tried to pass and couldn't pass, the Higher Education Acts that the Kennedys tried to pass but couldn't pass, or Medicare that the Kennedys tried to pass and couldn't pass, but they all got passed once he was killed, sort of by acclamation. Well, they're a mirror image of the Reconstruction laws almost from 100 years earlier, and most people don't realize that. Equal opportunity was the law of the land since 1865 until Reconstruction ended and it got reversed. And it took another 100 years for it to get revived. So what is its applicability to cultural competency? Well, first, let me just talk about what's called the Freedmen's Bureau. The Freedmen's Bureau was part of the War Department, what we call now the Defense Department. The Freedmen's Bureau was established because now the country had 4 million new citizens overnight because slaves weren't counted as citizens, right? So now all of a sudden they're full citizens. They got to look for jobs. They got to go to school. They got to get education, take care of their children. They have illnesses. They need health care, medical care. What is the country going to do all of a sudden? It's not like all of a sudden regular immigration back in those days when the boats pulled up from Europe and, you know, maybe a few hundred people or, you know, 10 or 50 people got off. He got 4 million people all of a sudden. That's now wards of the government, right? So the Freedmen's Bureau was the concept of Abraham Lincoln before he was assassinated. Go to the next slide. The Freedmen's Bureau primary purpose: education, health care, job placement. Go ahead. So I want to look at it from the historical aspect to what we have modern day. The genesis of almost half of the cabinet positions that we have in the United States were an outgrowth of what the Freedmen's Bureau was charged to do initially. Freedmen's Bureau was charged with helping the new freed populations with farming and providing food rations, because all of a sudden they don't work anymore. They don't have any way to get food. They can't farm any land because they don't own any land. So the Freedmen's Bureau was instructed to do this. That eventually became the Department of Agriculture. Employment assistance. Well, they had been working for free for 300 years. Now all of a sudden, you know, how do you get a job? Where do you get a job? What do you do to try to get a job? They had no concept of these things. You're just free. You're left on your own. So the Freedmen's Bureau helped them with employment assistance. So that was like looking over contracts because they couldn't read, so you don't know what was in the contract. You think you're working for $1 a day, you're working for a penny a day because you don't know. You just mark your sign, you mark your X, right? That became the Department of Labor. Same mission, but that's what it evolved into. Housing. They don't have a place to stay, right? They're a freed population. Can you imagine 4 million people all of a sudden came here today? Trump would have a condition, right? You can't stop that many coming across the border, right? So this is what we're looking at. So they were tasked with providing housing assistance, helping them build, helping them rent. Now that the Civil War was over with, a lot of them lived on the military bases. They converted them to help house the freed population. That eventually became HUD, right? Housing and Urban Development. Building schools. For 300 years, it had been illegal to teach slaves how to read, how to write. If you were white and you were doing that, you might get some lashes. If you were a slave and you were caught learning how to read, that was the death sentence. It wasn't even 3 strikes, right? And you didn't have to go to court. They just take you out by a tree. Send out the message. You're not supposed to be able to read and write. Now today, that's Department of Education. So these are things that were never taught in school, how these things had their genesis and where they came. But these were the outgrowths of all of them. And then finally, healthcare. And that's the topic that we're going to talk today. So when the slaves got sick, unless it was the blacksmith or the up in the big house, the slave woman that would be over all the cooking and stuff, no one got any regular medical attention. But what the slaves had and what they brought over with them from their different countries in Africa was a history of remedies, roots, that sort of stuff that worked on ailments, right? Today we call that alternative medicine. But that's where it came from. And so healthcare was the final thing that the Freedmen's Bureau was in charge of with the new freed population. And so why healthcare? Why healthcare? It was dire, right? The war was over. You got a new freed population. A lot of them are sick anyway. What do you do? At that time, there was no concept of health insurance, right? Everything was private back then. Education, medical care. So if you got sick, you went to the doctor, you paid when the doctor showed up, right? The little black bag came and saw what was your, or maybe your problem, and you paid then. Well, slaves didn't have any money. Freedmen didn't have any money. So it wasn't like the doctors or the next line there, hospitals and doctors couldn't be counted on. They absolutely said, no, yeah, they're free now, but I don't have to treat them. They don't have any money. And there was no concept to make you, the Hippocratic oath. There was no enforcement of that, which shouldn't, it's a moral oath, but they weren't doing it. And then because they were now freed and they were congregating in certain areas, for instance, Washington, D.C., saw like a third of the freed population tried to find their way to Washington, D.C. because they viewed Abraham Lincoln as the Father Abraham. So they felt more safer being near the father. But that brought pandemics of cholera, poor sanitation, so it was frequent outbreaks of diseases and illnesses. And so what do we do about that? How do we help that? Well, the Freedmen's Bureau came up with some innovative concepts that cultural competency has its roots in today. But we never taught that. We think that this is something the Joint Commission came up with their family-centered care or their LGBT-centered care or the class standards from the Department of Health and Human Services. These are where all these are generated from, right? So the innovative ways that the Freedmen's Bureau established healthcare is that I'm not going to go in the order that they're in right now, but one of the things that they decided to do was that the third bullet, they started having mandatory visits to the freedmen's homes. House calls. That's how it started, right? They came in and inspected the homes, they looked at the sanitation conditions, helped clean up, make recommendations, came out there with the medical care. And because they were part of the War Department or the Defense Department, the use for the Army hospitals weren't in demand like they were during the Civil War when it ended. So General Howard, who was one of the major generals of the Civil War and was the administrator of Freedmen's Bureau, he did what the Kennedy administration would do 100 years later when it came to schools. He basically took over the hospitals that weren't being used and turned them into hospitals for the freed population. 100 years later, Robert Kennedy would do the same thing in Virginia and in the South when the public schools closed instead of integrating. The federal government went in and opened up all those closed white schools and called them free public schools. Of course, General Howard called these free public hospitals. So 100 years later, that's where the genesis of all this came from. So we started converting Army hospitals that weren't being used to care for the new freed population, creating the term public hospitals. Because at that time, everything was just private, right? So what are we? were a public hospital, right? They all started with these land grants back then to create the public hospitals. They provided, so this is the cultural competency point. Bureau agents all of a sudden now had to become healthcare practitioners, regular employees that worked at the Freedmen's Bureau, because you couldn't count on the doctors and nurses. They would be like our church people, right? They would be like our church people. They came in and did the things that doctors and nurses couldn't do. There were some Army doctors that the general ordered, had to give an order for them to go do things. But a lot of the healthcare concerns were taken up by the regular people that worked at the Bureau, that they had to go through this training, and then they were able to be launched out into where the free population lived, or the hospitals that they were at, and provide health care to them. And then finally, General Howard saw the turnaround in the curing of illness among the free population, that he expanded his control to not only hospitals that were not now being used by the Army, but even those being used now had a ward for the free population. Now I'm going to take a pause right here. Can anybody tell me the significance of General Howard? Does that name sound familiar to you in Washington, D.C.? Is there a university or a hospital you can think of? General Howard, that's where it came from. As a matter of fact, most HBUs in the South, they are named after generals in the U.S. Army on the North. That's where they get their names from. Those were all the generals that after the Civil War ended, Congress put the South under military jurisdiction, divided it up into sectors, and each sector was controlled by a general. So General Howard controlled the capital section. And these are some of the other ones. Innovative ways that the Freedmen's Bureau provided medical care to the new freed population, right? Established free clinics for basic medical care. When President Obama had campaigned that first time in 2008, he was talking about the public option. This was what started the public option, right? The freed population didn't have to pay for their drugs, right? How could they pay anyway? They weren't working, they didn't have any money. So why would you go sell them something? They're not going to buy it anyway. So this is how we started with our prescription drug coverage and everything. It all has this genesis in the Freedmen's Bureau. So now we're going to switch gears. I wanted to give you that background so that you understand the genesis of all the things that we're required to do today as healthcare practitioners, right? It's not like a group of men and women got together 10 years ago, came up with cultural competency and what we're going to do and how we're going to do it. All of that started over 100 years ago, but we're never informed of that. We're never taught that. So today, cultural competency in healthcare, this is how the Joint Commission defines cultural competency. I'm not going to read it. You see it on there. One of the things that is novel about it is that it included language for the first time. But language, so when you look at the Civil Rights Act, most people are familiar about Title VII, employment discrimination, right, as the Civil Rights Act. The Civil Rights Act has 12 titles to it. Title VI gives it oversight over hospital functions and colleges and universities or any organizations that receive federal funding. That comes from Title VI. And in Title VI, language is included. So this is because a lot of our population, English isn't the primary language. So if they come in for service or assistance, and you deny them that because they're not speaking in English, then they can have a Title VI claim against the hospital or the university. Now, icebreaker. For those of you who may have attended the cultural competency training that we used to do years ago with Edison Bond when he was over patient relations, the remaining portion of the slide is going to be really some of that training that we did back then. And I'll just preference that is that training was brought about because, as you know, as from overnight we discovered the hospital was in debt, something like, what, $150 million? And we were on the verge of being penalized because the Affordable Care Act had just come out. And one of the things, one of the penalties in the Affordable Care Act was that if your patient satisfaction scores didn't at least reach your state level or the national level, you could lose at the beginning up to 30% of your reimbursement. And it just got higher. Private insurance saw the federal government doing that, So they up the ante. They don't want to pay no money anyway. So if your patient satisfaction scores were low on private insurance, you could lose 50% of your reimbursement. So now it was incumbent upon us, because as a safety net hospital, the majority of the money we get to operate is federal reimbursement. So Edison Braun had approached me. We didn't contract it out. We got together and designed our own training. And 2 years later, Downstate received the Press Ganey Award for patient satisfaction for the most improved scores in patient satisfaction, which helped us not get penalized by the Affordable Care Act and not take away 30% of needed money that we had. So now, look at this picture. If these two individuals was to come into the hospital now and you're at admissions or you're one of the greeters, customer service, what do you think you would need, or what would you think would be their issues, just looking at that picture? There's no wrong answers. Any idea?
Well, for the elderly lady, she might need home care. I don't know if she's a nursing home here. Probably need home care services.
And why would you say that? Because she's elderly?
Well, some assistance in the home and depending on her ability to.
Okay. All right, good answer, good answer. Okay. Good answer. Okay, so pediatrics, okay, all right. So pediatrics, home. You? Yeah, she has a walker, right? She might need a wheelchair right away, right? She's coming into Downstate up that longest ramp in the world. she might, and it don't get any better, right? It's just forever it goes on, right? So she might need a wheelchair, exactly right. Anything else?
If I saw her in primary care, I would say, so I see you enjoy playing music. Tell me more about that.
Good, good, good. Arthritis, how do we know she has arthritis? You know, fingers? Yeah, okay, all right. Like Sweeney?
Yeah, looking at her hands, we would assume that a lot of times people have deformities without pain and they have pain without deformities. So
Sure.
we can't assume, we need to ask.
All right, I'll take maybe one or two more and then I'll.
So just as a pediatrician, we can't assume that she's not his guardian because there are a lot of grandparents that take care of their grandchildren.
True. That's true. One more?
There has to be another adult somewhere within this space. Because we see
No, there's not. There's not. These are the only two.
you know, we see an elderly person and we see a young person. So maybe two of them came in and a third person somewhere parking the car or doing something. So there's a lot of, you know, there's a family.
They caught the bus, went up that long ramp. They standing around, tired as hell. Ain't nobody come up and help them out with nothing yet, right? Dr. Lucchese.
So that young man looks very enamored with the piano and the way she's playing the piano. He needs the opportunity to learn how to play a piano.
True.
What about a social worker?
A social worker, yeah, right? So some of the other responses that we would get when we do the training is that maybe we need an interpreter. Maybe the kid interprets for grandma, or maybe grandma interprets for the kid. We don't necessarily know. May need geriatrics, you know, that sort of stuff. But there's no wrong answers. This is just helps you build the awareness that something is needed in addition to just asking the questions that's on the sheet of paper in front of you, you know, trying to get demographic information, right? You see, you know, this is kind of chronic right here. So you know that in addition to getting that standard demographic stuff, you're going to need something. If she's standing there, the wind blowing, and you're sitting at your desk outside, and you see that she can't get up, what are you going to do? You're going to wait till she come into the building after all of that, right? So this is the awareness that you build with cultural competency, right? We want you to act. And this is just a general definition of culture. Language, values, beliefs, that sort of stuff. Different populations, you know, have that. For instance, where you work at has its own culture, right? Everybody talk about the downstate culture, whatever that is, right? Basketball team got its own culture, right? That sort of stuff. So that's basically what it is. You can narrow the population as narrow as you want to come up with whatever culture that it is. So these are some of the traditional manifestations of cultural diversity. These are things you see with your eyes, right? You're only using that one sense. So you can see these things right away, right? In most cases, right? Go ahead. These are the unseen things that you don't know right away. You might see a physical disability, but you can't look at somebody and know that they have high blood pressure or that they have cancer. You can't tell that by looking, right? You can't tell their sexual orientation status, by looking, right? Makes a lot of people uneasy. And we have undocumented status, so this makes me laugh a bit, I laugh a little, because when we were originally doing this 3, 4, 5 years ago, Trump wasn't in office, but what happened with the undocumented status when the Affordable Care Act was being debated, one of the things that the draft versions wanted to do was have hospitals take verified the documented status of the patients. And the hospital lobby refused to do that, so it never got part of the Affordable Care Act. But, everything that's old is new again. And then finally, you don't really know if somebody is a veteran, unless they're coming in their, ex-uniform or that sort of stuff. So these are some of the things that we don't see. So we have obvious manifestations and we have less obvious manifestations. Admissions, I know these are the things that we already do here at Downstate when they're coming in. Just want to sort of reiterate this. Really, I gave those multiple greetings in different languages because I knew I was going to come to this slide, because what we want to be doing, if we're not doing it, I'm sure we are, we want to ask the patient, what is their preferred language? Sometimes we assume just because they're speaking another language that they want it in that language, or we think that because we speak English and you don't speak English, there's something wrong with you. But, the patients will probably interact with you a lot better if you ask them what language it is that they want to discuss their health care in, right? They may not want to talk about it in English. They may speak English like I'm talking to you now, and then you ask what you want to talk into, and they know, hablo español. You'd be like, oh, heck, all right, I got to go find somebody. But then that patient will be free to give you the information that you need, to make the right prognosis or diagnosis and send them where it is that they need to go to. The next one, the sensory or communication needs. So we go back to the picture, right? And we saw grandma, right? So one of the things that we need to do is observe before talking sometime, right? We see grandma in the wheelchair. Do we really need to go ask her, does she need a wheelchair? Ma'am, I'm sorry, would you like to sit down? You see her struggling trying to get up the longest ramp in the world, right? And then finally, when they're filling out their admissions forms. So do we still use the forms? I know a lot of places where I go to and talk, they come out with little mini pads, iPads. You do all your admissions on that, and that's it. But I think we still got all the paper, right? So if you see them taking too long, go out and ask them for assistance. Because they may speak English, but they may not read English. That's the other thing that we take for granted, right? I can read the heck out of French and Spanish, because in the Romance languages, the vowels have one sound. They're all long. So you can read it for days. I don't know what I read, but So that might be going on with the people in admissions. You had a nice conversation with them. You got everything. You gave them to fill out those forms. Maybe it's 10 questions. And an hour later, they're still sitting down with the form. They're too embarrassed to come up and ask you for help. So, that awareness that you get, from the cultural competency training, you'll go and ask, ma'am, can I assist you with your forms? Do you want the forms in another language? I think we have them printed in different languages, don't we? Yeah, do? Yeah. Well, hopefully we got them in at least Creole and Spanish, right? Okay. No, leave it right there. This is a good one. So this is just some of the standard information that we would collect, right? So now look at the second one. Remember, we go back to the picture, and you're talking to grandma, and grandma not responding. Maybe grandma not hearing you, right? Is there some assistive device that she might need or that we may need to bring somebody out here, right? Or there anything else that the patient might need? So what I want you to take from this is that there are other things that are just as important in the admission process than the 10 or 15 questions on a sheet of paper you gave them, right? That's going to tell a better story to us so that we can provide the care that is needed than just sitting there seeing them struggling for an hour to fill out 10 questions, right? So we want to be able to have that awareness that we know that there's some need, some assistance that needs to be done once we give out that sheet of paper to them. And then finally, the last thing on here, if you see any unique needs, we need to send that information to the care team, whatever that might be. If we just go back to the picture, we see the little kid, maybe the little kid, maybe he's the one in pain. And grandmothers and grandparents, they'll walk 10 miles in a hurricane with the grandkid to bring them in there, right, and never say much, right? Or maybe she can't speak English, so we need to find out, is there something unique going on that the questionnaire we just gave you doesn't get into. And so this is how we acquire the cultural competency. You have the training that helps you become more aware, and then you're able to hone that training in, as you see those kind of conditions, right? Next time we see grandma walking up in the hurricane, we out there right away as soon as she get off the bus with that stroller, right? We ain't sitting there watching. She's off the bus. She's coming up the ramp. Nobody moves, right? We done been to the training. We're culturally competent. We got our awareness. We zip in. We sending security out there right away, right, to help grandma come up that ramp. And this helps us improve our skill set and each encounter that we have with the patient. Because ultimately the goal here is positive patient satisfaction, but also we want to provide whatever sort of healthcare remedy that we can to them while they come here, and not have them be repeat admissions all the time. And that was one of the things the Affordable Care Act addressed, is that these repeat admissions all the time. You have people coming in 1 month 15, 16 times, seeing all the same docs, running all the same tests. One thing that I would give the Obama credit for is that, oh no, you ain't getting paid for this. You sent this to us 10 times already, the same exact thing. I think we got, 3 times, I believe it was? And then they want you to get them into wellness after that, not keep running the same tests, every week when they come in to find out what's going on. Next slide. And so now we want you also to be interactive with the patient, right? Ask your patient, some questions. A lot of the times what happens is that, it's in law we call it an adhesion situation, meaning that one individual has more power than the other. So the doctor got more power than the patient, the nurse got more power than the patient. And then you got to remember, English might not be the patient's preferred language. It might be grandma, right? So they probably just nodding their head every time you say something, right? Nodding their head, nodding their head. So break the ice, interact with them. One of the things that we encourage you to do is, like I did in the greetings, is try to say a few words in their preferred language. You don't have to be fluent, right? They know you're not fluent by your accent, right? All right, we'd go up with Edison and we'd make the rounds. So I didn't tell Edison this right away. I'm going to speak some in French Creole, and Spanish when we go see him. And he was like, how do they all know you all the time? Because I go up there and just say, buenos dias, ¿cómo está? All of a sudden, when Edison said he would walk back up there without me, he'll be asking, where's Mr. Antoine? They knew he wasn't a doctor. They thought I was a doctor. I would just, bonjour, comment allez-vous? What they see is the honest attempt of you trying to reach out to them, right? Trying to communicate positive. You're trying to do something that you don't know how to do, is talking their language. And they appreciate that because they're in a conversation with you that they're unsure of themselves. They don't want to say the wrong thing. They don't want to seem stupid. So they're just going to shake their head like they understand. They probably don't know what you're talking about, right? So be interactive with them. Sometimes what we see, one of the big complaints that we used to get is that the healthcare practitioner, I always like to act this part out, right? So I'm the doctor. I'm going to use your paper. Looking at your chart. Gone. Well, if I'm the patient, if I came here for some minor stuff, I must be wrong. I must be deathly ill, man. He ain't say nothing to me. He ain't say, oh, hey, don't worry about it. You be out in the day. I'm like, oh, man, what the hell I'm in here for now? Or it could be the other way around. You are in here for some deadly stuff. He's like, oh, it must not be nothing wrong with me. They didn't say nothing. You on your cell phone. Girl, come get me in about 10 minutes. Doc didn't say nothing. Right? So be interactive, you know. Say something to the patient. You know, how are you? Buenos dias. ¿Cómo allez-vous? You know, that sort of stuff, right? Oh, what do we have going on here? How do you feel today? That goes a mile with the patient. A mile with the patient, because the next time, like I said, when Edison would make them rounds without me, they'd be going, so, yeah. What Mr. Antoine at, Edison? You're like, yo, man, how they know you? And then finally, you know, ask them their opinion, right? You know, I talked about it in the beginning how, you know, the new freed population, why they didn't have any medical training, hadn't gone to medical school or nursing school, they knew all the roots that would cure the kind of medicines, you know, kind of illnesses that they have. Well, patients may be doing that same kind of stuff, right? They come from different countries, right? South America could be coming from the Caribbean. They know when you got a cold that there's something you can do. I used to tell this story that my grandparents down in Mississippi. So, you know, I got a brother that's a doctor. I'm the lawyer. We like, you know, the big shots and all that kind of stuff. And grandfather was real sick, but wouldn't tell anybody. Wouldn't say anything, right? My grandmother used to go out and mint tea was the cure for everything, right? It grew right by the steps, right? Get that mint tea out. You don't shake the dirt out of nothing. Put it in a pot. You boil it. Drink that mint tea. Cure blindness, right? You got one leg short. It's as long as the other leg, right? I'm giving Grandpa mint tea, right? So, yeah, he went up, you know, with my brother one time. You know, oh, he put his grandson the doctor. Oh, it was like big news, right? Oh, my doctor grandson taking good care of me. You know, he brought him up there and everything. And left him in there with the docs that were my brother's friends, but, you know, he's a plastic surgeon, so he didn't get into what was going on with Grandpa. So anyway, you know, if you're from the South, you talk a lot, right? You got to have a story. I can't answer your question right away, right? So the doc went in there and asked, you know, old Grandpa Antoine, so Grandpa, tell me what's wrong with you? Well, let me tell you, about 5 years ago, I was out on them back acres, right? And we were shucking that corn and I felt something crack. I ain't know what it was. I just didn't pay it no mind. 2 years later, I heard the same thing. By that time, okay, all right, no, that's not what I meant. I mean, what's going on with you now? But see, now you know hurt Grandpa's feeling, right? Because now he can't finish the story. He probably ain't going to tell you another daggone thing. Going to be quiet, right? Simple as that. But let's rewind, like the rappers do, right? You let Grandpa finish his story, right? And you say, so what you been taking? Oh, you know, my wife gives me that mint tea, you know, them teas that we got going right by the steps, and I feel a little better. So now, pause. What do? Do you say, nah, that tea ain't working? Don't take that tea. It ain't doing nothing to you. Exactly. You don't do that. If the tea is not harming him, right, leave it alone. If you go in and say, well, look, there's no medicinal benefits to drinking that mint tea. I'm going to prescribe this and give it to you. Now, he looking at Grandma a little different. Grandma, that tea ain't been helping me. That's why I've been going to the bathroom at night. I've been drinking your tea. You done messed up his whole 50-year marriage at that point, right? He probably never going to leave my brother, right? He can never go back home to Mississippi. But suppose you say, well, you know what? That home mint tea that your wife is making, I'm going to tell you to continue to do that. And in addition, I'm going to have you take these and I'm going to explain to you what this is. All of a sudden, Grandpa on top of the world. Because his favorite grandson took him to the big city. He got the cure he was looking for. It might have just been some aspirin, who knows, right? But it's the confidence that you gave the patient. You listened to him and you heard him out and you interacted with him. religion. So here in Brooklyn, you know, we have Christians, we have Judaism, we have some Hindi, we have Orthodox Christians, we have Protestants, right? You can never confuse the Catholics with the Protestants. You can't say Christian, right? Because rosaries might not mean nothing to a Baptist, right? So you gotta, so what we want you to do is you don't have to be experts in everything, but you have to know the little nuances with your patient, right? With your patient population. So, you know, ask the patient about their, you know, religious or, you know, spiritual practice or their histories. You know, for instance, if I'm a Jewish female patient and the healthcare practitioner is non-Jewish and male, she can't say nothing to you. You can't ask no questions. You certainly can't touch. But if you don't know any of this, you think the patient is being uncooperative, right? You calling patient advocacy or something. You calling security folks, or you writing up in your notes, patient unresponsive, that kind of stuff, right? But if you know these little things, then you know, oh, wait a minute, you looked at the chart, so I can't ask any questions. I need to go out and, you know, either get permission, she needs to get permission from her rabbi, have a family member come in, or we need to go get a female healthcare practitioner. Doesn't have to be Jewish, but they need to be the same gender to get the information that we need. These are the things that you know, patients look for, and that also help get us out of liability. Here's the one that's very crucial, but is underplayed. When we're scheduling our patients to come in, most of our computers just have the Christian holidays on them. That's it. You see Easter, Christmas, right? That kind of stuff. So we're like telling them to come in, you know, come in on March, whatever, you know, yeah, it's not it's before Easter, it had nothing to do with Lent. But if they're not Christian, it could be falling on one of their high holy days, right? And so you always wonder why, you know, Kevin Antoine don't never come in when I schedule his appointment. He always call up and want to change the appointment. So now you found out that he's Muslim, and you keep scheduling his appointments on days that are sacred to him and his religion, right? Once you've uncovered that, then your relationship with that patient becomes better, because now you oh no, he's not going to come in on that day. So these are the things that we have to do, right? And I guess this is cured by whatever software that we're using at admissions. I mean, some of the calendars now in any software, they already have it. It's just a selection that you have to make, you know, what holidays, what religions, and you click it, they show up right there on your calendar. So it used to be when we first started doing this training, you had to go buy all the special software. Now softwares are so smart that now they come with the templates that you just click. You know, I need Jewish holidays, I need Muslim holidays. You see all that on your calendar, and then you don't have this kind of conflict. Be respectful about their end-of-life beliefs, right? There might be, in their customs and practices and religions, there might be some things that they need to do before they want to say goodbye to their loved ones. Or if you're some religions, they have a time period after death when the body needs to be prepared and all that kind of stuff. So you can't stay in your, you know, American Protestant or Catholic, you know, sort of mind frame on all that. These are the things that need to be discussed way ahead of time with the patient's family. And be respectful about gender preferences. I'm going to get more into that. I think we have one up here on LGBT. And then the other thing is that, and this is one of the, when we do get complaints on the patient side, this is one of the ones that stick out. We always want to come in and offer to say the Christian prayer to the patient population, right? We all bow our heads, our Father who art, and we're like, what? They won't say nothing right then. They're just going to get through it because they're worried about, you know, they won't say nothing there, but then, you know, we get that little email, Mr. Antoine the other day, the patient, dear Miss Goldsmith, right? So you got to understand that if you know your patient, then you know that that's a no-no. And don't remember, it happens more within the Christian denomination because there have been a few times where the Catholic doctor wants to bring out the rosaries. Are they Seventh-day Adventists, Methodists? They won't say anything, and then I don't want to file a complaint, but I just want to make you aware, Mr. Antoine, that kind of stuff, right? So if you know your patient and you know your patient population, these things won't happen to you. Now, when Edison and I, when we were doing this training, this is probably the one that caused the most hostility with the people in the training. It just felt unglued, right? So we used to do this kind of thing that we called role play, because the Joint Commission, you know, they have an LGBT-centered, patient-centered care standard that hospitals have to comply with, right? It's part of the accreditation process. That when they come to accreditate you, especially they come in on these no-notice kind of things, they may just come in and look to see, how are you handling this? How are you gathering this information? So here's a couple of things real quick I'll just say. With respect to the federal law, right, your LGBT status is not a protected category, right? It's the traditional, what we call, and Miriam knows this, and Shondell knows this, the protected categories. It's race, religion, gender, disability, color, national origin, right? But some state laws have made this a protected category. New York is one of them. In addition, the Joint Commission has made it a protected category. So now you have to navigate as to how not to upset the feds, but be in compliance with your state law. So these are some of the things that you can ask, because sometimes people just get too offensive if you're going down your little checklist, you know, race, ethnicity, religion, disability, you know, sexual orientation, and they got these little sub-boxes that drop down, you know, transgender, LGBT. You bring it back in. So one of the things that we used to do is say the patient didn't check off anything about sexual orientation, right? So either that means they're straight or they don't want to disclose it, but we're trying to collect the information. We can't force them. So how would you bring this to the patient's attention?
How would you like to be addressed?
That's one way.
Some people don't want to be called he or she.
That's pretty clever. That's right. I don't want to tell you how I want to be addressed. My name's Kevin. That ain't enough for you? These are some of the responses that we get. See, right. So what we want to do is really, we want to make it less offensive, right? So instead of asking about the sexual orientation box, you may want to say, oh, sir, I can't read your handwriting. Can you tell me who your next of kin is? Can you tell me who your spouse or partner is, right? So Kevin might say, Steve. Steve is my spouse. So I done got the information I need right there, right? Without having to ask, you know, sexual orientation. Mr. Antoine, you ain't fill out. You got to check. You got to check your sexual orientation or tell me your status. You ain't put no check here. Take the paper back, put the right check, and bring it back up to me, right? There's a lawsuit waiting to happen, right? Something waiting to happen anyway. Don't assume that you know, all right? I like to tell this little story. When I worked at another college in Staten Island, the English department was hiring an assistant professor, right? And they thought they had hired Julie. Came dressed like a woman, looked like a woman, everything, right? They hired Jack. He showed up to work the first day. So what, right? They assumed that they was hiring a woman, right? And then, you know, even when we go through the search committees, we have on one of the sheets that we provide the committees, we have the appropriate, inappropriate questions that you can and cannot ask. You know, and that's one of them. You can't ask anybody what their gender is. So what we want to do when we're collecting this information, because we're in New York State, so we're sort of straddling federal law, state law, and compliance with the Joint Commission, is that we want to be as least offensive as we can in gathering this information, because it's sensitive. Some people won't have a problem telling you, some people will. So we want to sort of ask these sort of neutral questions, right? Give me your spouse name, your next of kin name, you know, even if you can read it, right? I'm Kevin, and I got down there Jackson, right? Or I got Steve. And you thinking in your head, assuming gender identity, nah, Kevin look too suave, man. He tie on, got that little gray in his hair. No, that be, right, that look is judgmental, right? All of that. Nah, it can't be Steve. I'm gonna ask him. He's gonna call me back up, right? You can't do that. And the learn model, I kind of went through this when I went, with Grandpa. But this is what we have to do more of, right? We have to listen to the patient, right? I mean, we know they got bronchitis. We listening to it. We know what the cure is. But the patient might think he got something, but she may think she has something else. Just hear them out, right? Don't do this. I'm not going to touch you. Yeah, my wife been telling me, this is the patient talking, my wife been telling me I got some kind of, I know I ain't got no cold. She bought them old cheap cigarettes, got me coughing. Right? You don't want to say, no, it got nothing to do with the cigarettes, Mr. Kevin. You don't want to say any of that. Well, I know cheap cigarettes will do that, Got to get the good ones if you're going to smoke. But I think in addition to that, you might have this, Mr. Kevin, You want to be less offensive, right? You want to, what Dr. King used to do when he would go out in the places where he knew he was unwelcome, right? So he would say, well, I want to disarm them with love. I want to disarm them, that they don't know what to do, right? So that's what we want to do. We don't want to come to the patient, right, assuming everything, because we're the all-knowing doctor, all-knowing nurse, all-knowing PA, right? Yeah, you don't look well at all. You sure? Yeah, you got pneumonia. Hey, no doubt about it. I don't even take your temperature. You feel hot, right? Might be this August, 90 degrees. She drove in a car that ain't got no air conditioning. You don't want to take the temperature? So those kind of things, right? Don't assume to be all-knowing. And then like I just did, explain what it is, right? So in addition to them bad cigarettes, yeah, it looked like that you might have this, and this is why I think that you might have it. I listened to your lung, I heard this, I heard that. Do you wheeze sometime? So that could be it. So be as informative to the patient, but at the same time, be respectful, right? I mean, does anybody remember, how many people have had to stay at least a night in a hospital as a patient? You remember that first night? Well, but it's that first night you don't know, right? You in a cot basically with a sheet over it, right? Got that gown on, and you don't know how to, like, for me the first time, I didn't know that the opening part was supposed to be in the back. It's a gown. It's a robe. That's what I thought. I walked out to go get some water, and they're, oh, Mr. Antoine, you got your robe on back. I said, robe? My robe's okay. Right? You don't know. It's your first night in the hospital, right? You got people coming in and out of your room that you don't know. And if they haven't had their cultural competency training, they just coming in doing this. Or the next one come in, right? Ain't even flipped the page, looking at that same page and the same marks. No one said anything to you, right? Your whole night going like that, right? Your husband or your wife or your son or your nephew call you up. How you doing? They told you, no, about 15 people been in here. Ain't nobody say anything to me. I don't know what's going on. Acknowledge them. That's what we want to do. We want to acknowledge them, right? If there are different things going on, grandma's making that mint tea, you want to acknowledge that. Yeah, that mint tea is good. My grandmother makes that too. I want you to keep taking that, but I want you to try, this right here that we're going to give you, and I'll explain to you what to take with it. And you can take it with the mint tea. It actually works better, with the mint tea, right? Recommend and negotiate. So, we're not just there prescribing prescriptions to them and then we're out, right? Even today sometimes, because I know my doctors personally now, I always like to go see my urologist because he give me that good medicine. Like for him to be talking to me, I like to go to see my cardiologist. She gives me that good medicine. Keeps my heart right, keeps me active. Right? That sort of stuff. But there are times that we go and see our doctors or our healthcare practitioners, and they write out the prescription. never explain it, never say a word, just give it to you, right? The first time anybody even questions me about the prescription is when I go to the pharmacist, right? They ain't giving it to you unless you understand the questions that they're asking you, right? You ever had this before? Is that Antoine? Huh? Well, most of the time, we'll just talk in generalities. Most of the time, at least when I go, my pharmacist says, so you ever taken this before? You can't take it with this, you can't take it with that. So this is your medication, all right, so you get an automatic refill. Nothing that the doctor told me. Nothing at all. I won't say the doctor, but at the doctor's office, right, when the nurse gave me the prescription or whatever, the assistant gave it to me. Hadn't explained anything. So these are all the things that we want to do if we're going to be active with our patients, right? And because we are a safety net hospital, we want to keep our patient satisfaction scores up because we can't afford to lose any revenue from CMS on like just some stuff that we got control of. Question?
Healthcare providers negotiate cultural competency concerns with time constraints. Because I've noticed that doctor's visits got shorter and shorter and shorter. Sometimes I go visit my doctor and it's like in and out because there's so many patients.
Right. Well, I think that you would have more success if you're going to see your doctors at hospitals, or you could talk about that. You could meet with somebody at the hospital, patient relations, patient advocate. At a private practice, that'll probably be a little challenging. I'll just be honest with you. Maybe some of the doctors in here can answer that better than me. But at least if you're going into a group practice or a hospital, they have some specific policies and patient rights and that sort of stuff that they have to comply with. And then if they don't, then they can look into it. We have our patient relations office, and we have that committee that if the patient is concerned about something, they can bring it to the committee and that sort of stuff. But if you're in a private practice with 1 or 2 doctors, that'll probably be challenging. Yeah.
It's a choice. Educate the patient and let them make the choice instead of treatment.
True.
Grow in power and really allow the patient to self-manage, because when they walk out of the office, you're not there with them.
True. One of the things that I do, well, I haven't had to do it in a long time, but I just switch doctors sometimes, right? I remember years ago, this is how I went with my new cardiologist now that I've been with about 10 years. Prior cardiologist, I was taking the nuclear stress test. Fine. I got a bill from the vendor that they use to come in there, for a couple of $1,000. I got insurance. What is this? Oh, we don't accept your insurance. Right? Yeah, they should have told me that. Well, Lord, I got all that taken care of, but the fact is it pissed me off. And I had been knowing that doctor, for a long time. And all of us, they don't take your insurance. So I switched. I just switched, right? When I thought I had a good relationship with the doctor. Spoke with him, work it out. Was not really nothing I can do. Like after all these years, I didn't go back. I had my new cardiologist call over and just get all my records. So Dr. Vincent said, you can be in control of the situation. I don't think that I need to come in there and beg and grovel at you to correct a situation that shouldn't happen. There's too many other cardiologists out here that'll do the right thing. So I just switched.
So I have a question. How much of this is cultural competence as opposed to patient-centered care? Because one of the things that I tell students is this is what we should be practicing with all patients. Because I think sometimes people will say cultural competence and then treat a certain group differently because they're trying to be culturally competent, and in doing so, they're stereotyping, So how do you balance just recognizing, as you said, I love what you said, that you're not supposed to memorize every single group,
right?
But understand the subtle nuances, and I'm going to use that. I love that. But isn't this like just patient-centered care, meeting patients where they are, understanding their beliefs? So it's just in terms of patient-centered care.
No, I don't disagree with you.
I'm just saying,
Cultural competency is part of patient-centered care. It's just the cultural competency piece that we will be focused on some unique characteristics of your patient. So if this presentation was on how to interact with African Americans, I would go into more detail about African American patient. If it was Jewish, more details, dietary restrictions and that sort of stuff. But this is a general presentation on cultural competency for our patient population that we deal with. So, and that's why I said to you that You don't need to know everything, but you need to know the little nuances that are going on here. I want to get through the interpreters. Basically, what I want you to take from this is that, number one, remember that slide that I had a while ago? Family members can't be your interpreters when you're trying to get to what's going on with the health situation, right? They can give you some demographics, where they live, what the phone number is, and that sort of stuff. But as far as asking the grandson or the grandma what's wrong, can you describe it, they're not trained to do that. Sometimes hospitals have translators, but translators summarize, right? So they may be talking for 15 minutes, and they'll say, oh, he just said his stomach hurt, right? Interpreters give you the word for word, right, dialogue that happened. And so that's what I want you to take from your interpreters. It's all confidential. We have interpreters here. They have to be trained. If not, we can use the phones. But they understand the English terminology and they understand the medical terminology. And I just sort of went over that they're more than just a translator, and they're a cultural broker because they can understand the nuances. When I say nuances, Spanish spoken in Puerto Rico will be a little different than the Spanish spoken in Argentina, right? So if your patient is Argentine, you're not going to get an interpreter who speaks the Spanish from Puerto Rico. They won't get the little nuances. And just remember to, respect your interpreter. We don't want to have an issue between the healthcare practitioner and the interpreter in front of the patient, right? We always want the healthcare practitioner to maintain contact with the patient while the interpreter is interpreting. A lot of times you're looking at the interpreter, right? And then don't assume that just because the interpreter, once they've talked to the patient, right, and now they're talking to the healthcare practitioner in English, don't assume the patient doesn't speak English. They probably speak English just as well as you do. But yeah, they may not want you to know, but they may want to discuss their health condition in their preferred language. So you can't say stuff that is going to offend the patient because you believe they don't understand or speak English. And what I want you to take from here is that not all things in English translate word for word in another language, right? EKG might not mean nothing, in Russian, if you want to say you want to go get an EKG. So just say what it is, right? The machine that looks at your heart. Because remember, the American language, English language is very difficult to learn. One word can mean a lot of different things, right? Take fair. I treat you fairly. The weather's fair. How much the metro going to cost? Do I have enough fare, right? So that's the difference that, you take from a translator and from an interpreter. And then remember your body language, your nonverbal language, right? So if I'm talking to the healthcare practitioner and, I didn't like the perfume she had on, and I'm saying, well, she said her stomach hurt, and, man, I don't know what she got on, man. Do you smell that, right? So she's looking at your body, right? So she can tell you saying something, and they got nothing to do with why she's there, right? And then you don't know if she doesn't understand English or not. She might know very well, right, that you're saying something that's inappropriate at the time. And this is just a few things that I've already covered, the responsibility of the healthcare provider. Again, try to say something in the patient's preferred language, right? That helps with that trust, that lets them show that you're stepping out of your safe zone, to try to say something in their language like Buenos dias, right? Como wababu. Well, okay, he trying, he trying, and that goes, that'll go a long way. We kind of went through this with the learn model. I guess the one thing that I want you to take away from here again is that the interpreters, they repeat exactly what was said. It's not a summary of what's going on. And children under law, right, Title VI, cannot be interpreters, right? End of life care, I kind of went through some of this with religion, but you have to be mindful of the patient's families, religion, the patient's religions, what their customs are in end of life care. It may not be the appropriate time to talk about the living will, right just yet, because in their customs, there's some other things that their customs or their religion requires them to do before they get to that conversation. And then make sure that everybody has, access to the chosen support person. You may be thinking it's the spouse, but under their religious customs, it might have to be the clergy. It may have to be the rabbi. It may have to be the imam. You don't know, so don't assume just because if you were in there that the next of kin is your spouse or a family member. And so this is just a summary. I'm at my conclusion. Just remember that every population has a culture. A population just narrows down the category of people. You can narrow it from the state to the city, to the suburb, to the village, to the workplace, to your sports team, right? Be respectful to the patient. Be respectful to the interpreter, especially in front of the patient. And remember to consider, when you're doing the end-of-life care, to consider your patient's customs, belief, and religion. Don't superimpose yours on there, right? Don't say the Lord's Prayer, to the Jewish family, right? Don't bring out the rosaries to the Seventh-day Adventists, those sort of things. They can be innocent, but it's sort of like with a lot of our non-discrimination laws, is that it's how the victim interprets what you've just done, right? You could be doing it all innocent. They may look at it as deliberate. You don't know. So these are the little nuances that we have to be aware of. And then finally, just remember that things that we do here as a public safety net hospital reflects our bottom line, right? We're not assured any revenue off of private insurance that's going to keep us solvent. That's a very small, and Dr. Lucchese will tell you that's a very small percentage of how we earn our revenue. And we can't call it profit because we don't make a profit. But that help keeps us afloat. It's really how we take care of our patients. And now under the Affordable Care Act, the patient now has a direct means to influence how we get our reimbursement. Check to the right, check to the left on that patient satisfaction form, right? There's no middle checks. If he got more checks to the left, that's a possibility we're going to lose some reimbursement money. And these are the things that our healthcare practitioners need to keep in mind throughout the course of treatment to the patient. Not just at the end, because the patient is thinking about it throughout the course of the treatment. Yeah, Mr. Antoine came up there and said, come on down my last day. But hell, them other doctors and nurses didn't come see me, left my curtains open, right? When they get that, I don't know how we do it now. It used to be they got them in the mail, which, that's probably something we need to look at because that takes too long. If it was good treatment, and I don't get it for 45 days, I might have forgot all the good stuff. Might not even check it off. A lot of hospitals, they do it at that last day, when they're at the bedside, when they're leaving. So all that putting it in the mail, waiting for it to come. If you're going to do that, get an email address or something. But anyway, that's behind the point. What we want to do is that when they do complete their patient satisfaction form, we want to get them checks to the right. Because that's how we make our money. That's how we keep our jobs, right? We don't get that allotment from the legislature anymore. We don't get that $100 million anymore. That stopped in 2008. So our money comes from reimbursement from CMS and a small trickle from private insurance. And I know we ran over time. I'll stick around if you got some, questions, but I want to thank everybody for coming out today.